right, welcome everybody. Welcome to the Chair C Research Development Workshop on Implementation Science. I want to mention that Chair C has a slight change of name. We're now the Center for Heat, Health, Aging, Innovations, and Research Solutions for Communities. This change of name is to align with NIH priorities on health and extreme weather. And so our mission, nevertheless, remains unchanged. And just to briefly recap the mission, the long-term goal of our project is to advance community-engaged science on the adverse health implications of extreme weather exposures and to develop actionable solutions to promote healthy aging for all. And so that is our purpose to which we remain, Hugh, and we will be beginning our semester of activities with this workshop, but we also have a series called Accelerating Science colloquium that will be meeting on Wednesday afternoons from 3 to 4 in this room, and you can check out the agenda for those colloquiums on our website. All right, so today we're here to learn from Margaret Crane and Ruben Martinez about implementation science in climate and health. So let me tell you a little bit about who our presenters are. Margaret Crane is a researcher in implementation science in the Brown Research on Implementation and Dissemination to Guide Evidence Use, the BRIDGE program. She is also she just received a K Award, and so she will be transitioning into a assistant professor position. We think so. So Margaret received her BA in psychology from Harvard University, her Ph.D. in clinical psychology from Temple University, and her clinical psychology residency at New York Presbyterian Weill Cornell Medicine. Dr. Crane's research examines strategies to disseminate evidence-based practices for mental health. She approaches this by considering how to increase the supply of evidence-based practices through the combination of business models to disseminate and policies to fund these programs, as well as how to increase for evidence-based policies. Ruben Martinez is an assistant professor in the Department of Psychiatry and Human Behavior at Brown. He is also acting associate director of the BRIDGE program and lead for implementation for advanced RICTR. His research leverages equity-grounded implementation methods to strengthen health and mental health systems with a focus on youth, marginalized communities, and health equity. Dr. Martinez collaborates as an implementation science methodologist on projects spanning school mental health, HIV prevention and opioid use disorder care, asthma disparities in Puerto Rico, digital and virtual reality interventions, and suicide prevention. Through his research, training, and mentorship, he works to build capacity for implementation of science across Rhode Island and beyond. Thank you very much for kicking off the semester, and I look forward to hearing what you have to say.
Wonderful. Thank you for the warm introduction. Hi, everybody. We are really excited to be here today. This is Margaret really spearheaded this, but this is a very values-aligned organization for us to try and figure out how we can work together. And we're just really inspired by the work that you all are doing. So thank you for being here with us today. I'm going to introduce a little bit about implementation science, and Margaret's going to talk a little bit more about how it's applied, especially in relation to climate and health. Okay, so we're going to do the key takeaways up front. So this is what we're going to talk about today. We don't just need more evidence, we need implementation efforts and really actionable and feasible implementation efforts. We're going to talk about what that means. Implementation science is a way to help address this problem that we have a lot of evidence and the implementation typically of that evidence lags far behind. So implementation science brings tools like theories, models, and frameworks and specific types of methodologies to explore and explain the context rapidly. That's a relative term. It's not always super rapid, but it's more rapid than typical. Test strategies for best implementing the thing that you want to implement, and to evaluate the outcomes related to that implementation effort. Okay. Implementation science fits naturally into many grants and with any innovation, any sort of program or product or project. And there is an abundance of calls for this work. So we're seeing more and more that funding bodies are really prioritizing implementation science and essentially across all of the federal government. Okay, so this is a Menti. We're not doing a Menti, so please don't open this. We didn't actually do this. But what I am going to ask you all, when you think, if you've ever heard of implementation science or not, what are the words or words that comes to mind when you think of implementation science? And feel free to put it in the chat. I think someone's monitoring that, but also just shout out anything that comes to mind for you.
Real world.
Real world. Love it.
New ideas.
New ideas. Anything else?
Making things work.
Making things work. I love it. I love it. Okay.
Evaluating innovation.
Evaluating innovation.
Adoption,
And change. I love that. And someone on Zoom said something too.
adoption, reach,
Evaluation of
Effectiveness.
effectiveness. Yes. And it sounds like everything that we're saying, this sounds like there are real alignments with what you all do too, right? This is the sort of bringing the fruits of your work to bear. This is what this is all about. Okay, so what we find, has anyone ever seen a statistic like this? On average, it takes 17 years for 14% of research to make its way into routine practice. So there are differing stats about this, and there are some updated stats. Generally, there is some evidence that maybe this is getting better, but really we're still not really hitting the mark. And we're still finding that a lot of the research we generate, the evidence that we generate, is not being put into practice in real world settings. That change is not being made in a scalable and big picture way. And the takeaway here is that this is not an issue of not having enough evidence much of the time, although more evidence can be helpful. This is a challenge of implementation, is that we are not purposefully and planfully implementing these programs. And there's a lot of reasons for this, a lot of things that you all could probably come up with around the way that academics and researchers are incentivized, the way that our promotion structures work, the disconnect between academics and communities. There's lots of things that drive this gap, but it is a very serious challenge. We sometimes call this, there's a couple words for it. There's like the know-do gap, so the gap between what we know works and what people actually do. The other way to think about it is called the research to practice gap. You'll hear both those terms typically used in alignment with implementation science. And so this gap is really that we have a lot of evidence for things. Margaret and I are both clinical psychologists, so we spend a lot of time in the mental health world, but we have a lot of evidence for a lot of programs that work. We know that they work in the settings they're supposed to be used in, but when it comes down to it, they're not actually put into place. And if they are, those efforts typically fall away, especially when research funding runs out, those teams leave, and then all that infrastructure that was built in place for these grants, these projects falls away, and no change is actually sustainably made. So this is the area that implementation science really seeks to address. It's important, I think, to know that this is a fairly new field. The roots of implementation science, like through diffusion science, like starting with farmers back in the early 1900s, the roots of implementation science go far back, but the actual science of implementation, the terminology, the taxonomies that have been developed, the research strategies really started in like the mid 2000s, like 2006. And there was some discussion of implementation before that, but really this is when implementation science started really wanting to develop as its own thing. So we're talking about 19 years of a science. It's not a whole lot. So there's a lot of newness, and that also means that there's a lot of opportunity to innovate and to get into this space and leverage it for your own work. All right, and so I haven't defined implementation science, so I should probably do that. Implementation research is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. And so implementation science, I will say this, started a lot in this health space, social work, mental health. That's where a lot of this work was originally done. And I think that's because the National Institute of Mental Health was one of the original dedicated funders of implementation science. And so you see there, and also the National Cancer Institute, a lot of this work has really centered around those themes. But as more and more people have come to understand the importance of implementation, more funders are starting to call for this kind of work. Okay, so what do we do as an implementation scientist? Margaret and I are both implementation scientists. We do several things that are, I think, adjunctive and additive and very helpful. A lot of these things people actually do parts of in their own research. So we're not ones to gatekeep implementation research. A lot of you in this room and on the Zoom may be doing some facet of implementation research. It's just maybe the language we're using and the paradigms we use are slightly different, the approaches. So we do things like assess gaps related to the failure to use an evidence-based intervention. So we look for things like, we call them determinants, but barriers and facilitators through rapid contextual inquiry, things like rapid ethnographic assessment, rapid qualitative analysis of key informant interviews, focus groups, and things like that. So there's a very heavy qualitative component to implementation science. We test whether implementation strategies reduce gaps between research and practice. So one of the primary changes that people have to make is that we're really focused on the behavior of providers or of people who are in more of that service role. So how much are they implementing the thing versus how effective is this thing clinically in changing whatever clinical outcome it's supposed to change. We help to evaluate, just to take a step back. Implementation strategies are a really big term. This is something that feels kind of big and mysterious for a lot of people. Training is an implementation strategy, and the way you train is really important, right? So we know that going into places and doing 2-hour trainings and then saying, all right, now go do this thing, it hasn't led to the best outcomes. And so dynamic training strategies, continuous consultations, experiential learning, building in adult learning paradigms, that is something that implementation science would actually seek to test and evaluate. Does it make a difference in knowledge, self-efficacy, and actually the way that people are using a program or innovation? We evaluate implementation efforts, and that's through this analysis of implementation-related outcomes, which Margaret will talk about in a little bit. And then we have a really heavy emphasis on theories, models, and frameworks. So there was a lot of work done to develop these theories of how contexts function and how they function to impact how people use innovations. And we really leverage a lot of that knowledge as much as we can. So it guides a lot of the things we do, like the rapid qualitative work I was talking about is almost always guided by a framework of some kind. So we have implementation specific theories, and we also leverage theories from places like learning and cognition. Okay, so here is the very technical,
A really quick question. Another thing that we've been hearing a lot about is the learning health system, where a health system will employ or test things that they've been doing for a long time, quick rapids, RCTs, but within the real contour. Is that, I mean, it's maybe not that important a question, but I was kind of curious, how does that intersect with implementation? Is that part of implementation science, or is that something different? How do you think about that?
That's a great question. So the question was, how are learning health systems and implementation science related? They are very much so related. And this often comes up with the question of quality improvement and improvement sciences. So improvement science, which includes quality improvement methods and implementation science, are very related to one another. There's an overlap in the Venn diagram there. In terms of learning health systems are ways that we can actually practically use that implementation knowledge to put stuff into practice and feed it back into the health system so they can learn and then actually like iterate on what they're doing every time that they deploy an investigation like this. So learning health systems are a paradigm which you can use implementation science in. They often leverage improvement science as well. It's a great question. Yeah, learning health systems are very exciting for us. And a lot of implementation scientists are actually working on how do you implement a learning health system first? Because that's actually a very complicated thing to do, is to typically in healthcare systems, integrating and aggregating data across sources and then making decisions on what to do based on that information is it sounds easy, but is extremely challenging. And so there are people we work with who are implementing learning health systems, the infrastructure, the approach, the culture, so that they can do further implementation work within that learning health system. That's a great question. Okay, so actually that is a nice segue here. Thank you for teeing this up. In that case, the thing would be the learning health system itself. So what I want to get across here is that the thing you're implementing can be pretty much any new innovation, and it can be at several different scales. We're going to talk about all the different things the thing could be, but in implementation science, we have the thing. That is what you want to put into practice. It's an innovation, treatment, and intervention. Typically, we think of efficacy and effectiveness research as ways to look at, does this intervention improve the clinical outcome that it's intended to improve? So for us, where we work a lot with mental health, does our cognitive behavioral therapy for depression impact depression outcomes? The implementation research goes hand in hand with that clinical research to ask the question, how do we help people and places do the thing in the best way possible? So they're not at odds with one another. They're in fact very complementary. Implementation strategies is the stuff we do to help people do the thing. So this is things like training. If you're familiar with strategies like audit and feedback, where you actually, people are really good at overestimating how much of things they do and how well they do it. So you actually show them objective data of how much and how well they're doing something. There's lots of different strategies. Margaret's going to talk about that a lot more. And then we have these implementation outcomes, which is how much and how well are people doing the thing. Does this feel pretty clear to people? This is based on Jeff Curran's, this is actually a paper that got published, believe it or not, this exact model with these exact words, basically. All right, pretty straightforward. So yeah, in this case, the thing could be the learning health system. It could be a new type of air filtration system. It could be an approach to getting people to mask. Like there's all kinds of different things that the thing could be. Okay, and this is where we get into this, is that the Center for Implementation made this really nice graphic, and sorry, there we go. There's these 7 Ps, and these are the 7 Ps of possible categories of things. We have principles, programs, practices, procedures, policies, products, pills. There's all kinds of things, but they all fit pretty much neatly into these 7 Ps. So those are the kind of things we're talking about. Which leads us to our next question, which is also not a mentee. So please don't go to mentee and do this. But we wanted to hear from you all so we can tailor as much as we can the rest of this. What are the interventions, innovations, and programs that you're passionate about implementing right now?
Related to this topic, or
Just anything you're trying to implement. What could your thing be, is the question, if you were going to do an implementation science?
Biometric wearables for monitoring stress.
Okay. Biometric wearable for monitoring stress. I'm repeating so that they just, Great. Anyone else? I know you all have things that you're passionate about implementing or putting into practice. Yeah.
Communicating when there will be a poor air quality event so that people change their behavior to reduce their exposure.
Okay. I love that. That's a complicated one too.
Fortunately.
Yeah, it's multi-component. I see Louise has raised their hand.
Hi, yeah, I'm interested in compliance and engagement with recycling, reuse, and reclamation practices within the Brown Design Workshop, which is what I direct.
Awesome. That's great. Margaret.
Communicating heat health risk during pregnancy.
Heat health risk during pregnancy.
Right.
Anything else? Anything else that people are feeling like, I know what my thing could be if I were to do a study like this? Because it's important. So just to give you some background for why we think this is important is that oftentimes people think they know what their thing is, but their thing is not as well described as we would like for it to be. And for us to generate and develop a plan for implementing that thing, you have to know exactly what that thing is and importantly, what it is not. So you have to understand what the core components are. What are the things that make up the thing? Like what makes a sandwich, right? What makes a cookie a cookie? You have to know what makes it the thing, because if you don't know what makes it the thing, it's really hard to develop a program, a plan to put it into place. So that's a big thing that we talk about when we consult with folks is how do we help you define and describe exactly what your thing is?
Good question.
No, I have another example. Directing tree plantings so that they will cast shade over things that we want to have shade, like play structures and bus stops.
So cool.
Is to support pregnant patients with climate-friendly diets and developing heat action plans.
All right, these are some very well-developed things. So think about this as we go through the next part of our talk, because we're going to talk a little bit more about the other components of implementation research and how you actually operationalize some of this work. So thank you very much.
All right, so we were really excited to connect with this group because implementation science is just starting to be applied to climate health, climate change, whether that's climate health things. So some of the things you mentioned were more health related, or more kind of things like recycling, which aren't necessarily health related, but we can definitely apply implementation science to them. So I'm not going to go through these papers in like a ton of detail, but we'll send out the slides afterwards. Feel free to dig into this more if you'd like to see how some folks are starting to do this. So some examples that people have started to examine this area in is disease early warning systems. So how to more broadly adapt data systems to integrate meteorological and health data. I think you were kind of mentioning that sort of thing. Understanding multi-level barriers to implementing different programs, designing strategies to overcome these barriers. So these papers kind of talk about how they were applying implementation science to these different contexts. And then they also talked about how to analyze the ability of these strategies to advance uptake. So all those things are very squarely in line with what we do in implementation science. And again, they're just being applied to new areas, which is really exciting to see. This study looked at pandemic preparedness. Again, I'm not going to go into too much detail about this because you can read the articles yourself. I just wanted to flag some papers in case you do want to read more later. This study looked at conservation and health programs. So again, it's not just health related, but we can really apply this to the uptake of any new program policy practice. Climate risk mitigation. So things like heat, storms, vector-borne diseases. This paper also really highlighted community-driven approaches. And so, you know, as we talk about implementation science, even as we're meeting with you all initially, we were discussing how much overlap there is in a lot of the research processes we already do, specifically with community engagement. So implementation science cannot be done without engaging key partners. And that's because we don't want to be the holders of the implementation process. We want to understand what's going to actually work in practice. There's a variety of different levels of engagement, and you might see this in studies as you read about implementation science. You might feel this tension in your own work. So I just wanted to call out that, you know, I think it's important to be mindful of where you're at in this process. You know, are we co-leading this? Is this a project that perhaps our community partners came to us with this problem and we're going to help them solve it? Or are we more just consulting them? So getting feedback about, you know, barriers and facilitators. But I just wanted to highlight, regardless of where you fall on this, I think implementation science is really community driven, and I've heard a lot of your work is as well, which is great. There's a lot of overlap there. So in this part of the presentation, I just want to go over some kind of key questions that we ask in implementation science and introduce you to some of the frameworks we use. And so I don't expect you to be an expert after all of this, but just to have an idea that, oh, there's this framework that exists that I could maybe apply to my project. So the first is, this is called a process model, which basically means this, it's called the Query Roadmap. It's from the VA, which is Quality Enhancement Research Initiative. And so what this does is it helps guide you through the different steps of implementation to make sure you're not skipping a step. I think a lot that some people are naturally good implementers. They are very methodical. They think through all the different levels that could impact a program. They take a lot of time to plan. They take a lot of time to evaluate. However, not all of us are. And so I think that's where sometimes these implementation frameworks can come in. They also can help you compare across projects in these different stages. So in the pre-implementation phase, that's where you're defining what's the problem, who are the key people we need to have involved, what are the best practices? Does this match what they need and actually want? Then we move into implementation. So what strategies are we going to use? By the way, in pre-implementation, we also might do a little bit more work in defining like what are barriers and facilitators that are going to get in the way of implementing a program. In implementation, we identify what strategies we're going to use. We might adapt the program or policy to the local context. We'll define benchmarks of success and measure it. And then we want to look at sustainment. So again, in this framework, it's focusing on veterans, but this could be, adapted to any population. Thinking about things like who owns the process. What's the continued impact after the main implementation team leaves? How much do we need to have ongoing support? We often say in implementation that we want to plan for sustainment from the start. If we're not doing that, we might design a whole initiative that as soon as the funding ends, it's going to just fall apart. And I think that often happens. So implementation science has kind of a different set of outcomes than we look at in, for example, clinical outcomes or service outcomes. And so again, when you're thinking about like how well does my program work, that's kind of the equivalent of like a client outcome. Because again, a lot of implementation science started in the health world. But so we look at things like early metrics of success. We want to look at what, the feasibility of implementing a program, how acceptable, how appropriate do people feel like it is. Those are early markers that implementation might go well. If people don't think that this is an acceptable program, they're probably not going to use it. And so we want to make sure that our programs are feasible, acceptable, and appropriate for the context. This is where we might tailor the program as well if it wasn't initially feasible or acceptable. Mid-implementation, we look a lot at adoption rates. So how much is this being used? Fidelity, is this being used as we designed it? Are we using the core components of this intervention well? We also look at implementation costs. So cost is, of course, important to understand how much is this effort costing? Because if we want to scale this, we need to know how much we need to get funding for to get this implemented elsewhere. And then towards the end of implementation, we might look at penetration and sustainability. So this is like how embedded is this practice now within the organization? Is it being sustained over time? So I just want to highlight, these are the main outcomes we look at in implementation science. You can of course bring in other outcomes, but this is one thing that I think sets implementation projects apart, is we've kind of a different set of outcomes. But the idea is that if this is implemented well, that means the program is being used as intended. So therefore we expect the client outcomes or the population level outcomes that the program had in a very controlled setting. Implementation science has a lot of frameworks. I will just say this definitely intimidated me when I first was getting into this area. I've grown to appreciate them over time. And one thing I also want to mention is that there's a lot of frameworks that kind of sound similar and say similar things. That's true. And so if you're feeling like that and you're like, what's the difference between them? Like, there's probably not a ton of difference. People often kind of pick one they start with and get familiar with and keep using it. There are minor differences that we can definitely talk through if we ever collaborate, where you might pull from one framework for another. So I just wanted to normalize, if you're intimidated by implementation frameworks, that's normal, but I promise they're your friend. So determinant frameworks essentially look at what are barriers and facilitators to implementing the thing. And so the reason why I think these are really helpful is that they look at multi-level factors that might impact how well a program is being implemented. And it's useful to consider these from the start of a project because you can collect data at each of these different levels, or you can design a qualitative interview to make sure you're asking questions at the different levels. And then later when you go to analyze the data, you can analyze it using this framework and write it up. And journals like it because it's easy to compare across studies, and it helps us learn across these different health programs or environmental programs, what are different factors at different levels that might impact how these programs are being used. So the outermost level is basically the political environment, and the outer context. So this is everything outside of the organizational setting. Again, there's a lot of jargon in implementation science. You will get used to it, I promise, if you start doing this more. The inner setting, this is just organizational factors. So this is things like, what's the organizational culture? Is this mission aligned? Is there access to knowledge about the innovation? What are the available resources? What's the communication team like? Are the incentives in line? Is there any tension for change? What other organizational priorities do they have? So then I'm actually going to go back out to outer settings. So that's things like policies, financing, external pressure. So what are other organizations doing? Is there a culture of change within this city, for example? It looks at individuals involved. So this could be anyone from high-level leaders, managers, a front desk staff person is often like a key person within implementing something because they're someone who's really patient-facing. The beneficiaries or recipients, so that could be patients, but it's who's your end user. We also look at what's the implementation process like within this framework. So how well was this implementation done? Was it planned thoroughly? Have we tailored strategies? Did these implementation strategies impact this from being uptaked? And then we also look at the thing of the innovation. So what's the evidence base? Is there a relative advantage? How adaptable is it? Can people try it out? Is it very complex? So again, basically we would ask people in qualitative interviews is often how we assess this, questions about like, what do you think of this program? Maybe we might ask a more specific question of like, do you feel like you understand how to use this? Does this feel complex? And you'd code all those things under innovation, and that helps you basically organize your data. This is why these frameworks are useful. Any questions about this so far? So this is just a sample study of how they used CFR in a health project. And so some key barriers emerged, things like limited resources, political challenges, workforce capacity. They also identified facilitators, so things that help make it more likely to put something into practice, including collaboration and leadership support between U.S. state health policy agencies. So again, this study uses framework to examine the uptake of health interventions. So this might be how it's organized in a table. I actually just summarized this on the last slide, but again, looking at outer context, that's like the political environment. Is this a priority at the state level? Advocacy organizations, are they all on board on this? Is there a national attention to this issue? Inner setting, things like, again, funding, staff capacity, leadership engagement. Are the leadership on board and prioritizing this? Individuals involved, we often look at things coming from things like the theory of planned behavior. So what's their knowledge, belief, self-efficacy? And then the innovation funding timelines might not align with longer timelines that are needed for climate adaptation. And then in looking at the implementation process, this project used peer learning, community academic partnerships, and then they also evaluated efforts, but then really took time to celebrate internal successes. And one thing I just want to highlight with the implementation process here is the part of peer learning. What barrier do you think peer learning was addressing within these barriers within this table? Why do you think they use peer learning as a strategy?
Imagine that the staff of this organization may not, well, there are going to be different types of staff, and then the clients are going to come from different populations and may not fully understand one another for some reason that's specific to the thing.
Yeah, absolutely. So you were getting at individuals involved, and that was what I was thinking about too, of perhaps they didn't have knowledge so they could learn from each other. Given it's peer learning, maybe they had certain beliefs that they thought that peer influences and social norms could help change. And so by combining those two into peer learning, you could address a knowledge gap and you could address a belief gap. Let's say though, that wasn't a barrier in, when you did this sort of determinate assessment, you wouldn't want to use peer learning as a strategy because you don't need that as a strategy. So I think that's where doing determinant assessments first can be really helpful because it helps you identify what are the actual barriers in this project. Sometimes people know they're supposed to do something and they're just not doing it, in which case you need a different implementation strategy to overcome the barriers that do exist. So implementation strategies, this is the stuff we do to get people to do more of the thing. Basically, there was this big list that was created about 10 years ago that's kind of clumped into different categories. The thing I want to just highlight with this is in practice, we often co-develop these strategies with community partners. So we come to community partners and we say, okay, here are your, the strengths that we have here. Here are the facilitators, but we also know these might be barriers. What can we do to overcome this barrier? Maybe you'll look at this list to come up with some ideas, but usually you're using this very long list of 73 strategies or something. It's quite long. Usually you're using that after the fact to report it consistently within the literature. So while there's a long list of strategies in practice, you're going to be really co-developing them a lot. So that could be things like evaluation or interactive strategies, interactive assistant, adapting, tailoring content, developing relationships, educating stakeholders, supporting clinicians, engaging consumers, financing strategies, or changing infrastructure. Again, these are bigger buckets. Within that, like how do you actually use financing strategies? What does that look like? Are you paying people to recycle more, for example? Or are you making sure that something's reimbursed by insurance? So there's a bunch of different ways you can do this within these different buckets. But these are, when we talk about implementation strategies, this is what we're talking about. All right, within grants, so we were kind of alluding to the fact that I think there's a growing call for implementation within a lot of different grant mechanisms. I will say, unfortunately, some of this has changed recently, as you all are, I'm sure, very intimately aware with. The NIH previously had a call for implementation science and climate change and health. That call, of course, does no longer exist. That said, I think these methods can be applied to many different health areas and could perhaps be like one of the things that you say is an innovation of the project of we're applying these methods from this other area to my content area. There's specific implementation funding announcements from many of the different NIH institutes. I just listed a few here. I'm sure I'm missing some that have specific implementation science calls. But those are of course worth reading if any of those are, these are institutes you commonly apply to. Within NSF, this is a grant mechanism that we've used less of or we've applied less to. I think they talk more about knowledge translation. So I actually think this is an opportunity to be really innovative and apply implementation science to the NSF projects that you all might be submitting. And again, I think they appreciate it based off their emphasis on knowledge translation of how do we make sure this project is getting put into practice later on, but it's not necessarily something that's been like highlighted within funding announcements as far as we know. But again, I think that's actually an opportunity for innovation. Likewise, I think other grant agencies, I think most of them care about how do we make sure that the research dollars we're spending are going to lead to sustained improvements. So I don't know of specific implementation science calls, but again, I think you could apply implementation science methods, where again, part of the innovation of your study is applying these methods to a new field. I'm curious if folks have other ideas of like grants, mechanisms where you've seen implementation science as a specific field that's been called out. I think, again, this is an opportunity, though, that you could be innovative and apply something new, and explaining why implementation science methods might be helpful. Yes, we have someone raising their hand on Zoom.
I can put in the chat for those of you in the field of aging, the recently reauthorized Roybal centers. All of them now offer highly translational grants on a number of different topics, and some of which could be customized for environmental and climate change. And they're almost R01 level type grants that go through the Roybal centers. Probably some folks are already aware of this, but I think it would be appropriate for implementation science. In fact, it's even emphasized. So I'm happy. I'll put a link in the chat in a minute or two.
Awesome. Thank you for that. All right, we're getting some technical support. I pressed the wrong button. Great, I'm gonna pass it back to Ruben for more grant tips for implementation science. Sorry, let me grab you again.
Oh, the screen sharing is paused.
Okay,
There
there
we
we go,
go. I
sorry.
think that should work.
Ruben fixed it.
All right. Okay, so what I wanted to get across here is a couple different ways you could think about integrating an implementation science aim into your grant. So a lot of what we do have our own principal investigator research that we do, but a lot of what we do is as methodologists. So people come to us with their thing, their challenge, their grant, and then we build in an implementation science aim or a focus to their grant. So here's some ways that it might look. We talked about this, identifying barriers and facilitators to scaling climate and health interventions. So this is typically called something like a contextual inquiry or a formative evaluation. That's how it's nested in the context of like the language of an aim. And so this is really, as we talked about, identifying different things that hurt or help the implementation of your practice. And I think to put a really fine point on what Margaret was saying is that when we identify these barriers and what is present in the environment, we can then develop tailored strategies that address those specific barriers. And that's why that's the strategic process of moving through an implementation blueprint. So these blueprints really help us to structure the way we identify what is getting in the way. We then develop a causally plausible way of dealing with that barrier through an implementation strategy, right? So we have pretty good reason to believe that this kind of training, this kind of peer learning, this kind of X, Y, or Z is going to address this barrier. And as we do this blueprinting, that's how we're building it iteratively over time. So we're building strategies that address specific barriers for the context. So that's really how that blueprint works. And then we actually would integrate things like lessons learned. Is there any questions about, I maybe have confused things more, but does that make sense what I was saying about like targeting specific barriers with strategies? Okay, there's a question online.
Yeah. Do these strategies have to have evidence backing them before you pick them up as a solution?
That's a great question. It depends a lot on the type of grant you're applying for. So just like in any other type of grant, you might consider like an earlier stage grant, like an RO3, for doing maybe like a small pilot or even foundations to do a pilot. Like we are getting some initial signal that this strategy works if there's no evidence at all. But once you have and build more and more evidence, you can start to apply for things like an RO1, like the really big grants. So an example of this are like nudges in healthcare. So people receiving a text message or an alert through their health record system where it's encouraging them or reminding them to do a specific action, like review a certain document, give a certain vaccine, etc. Those were things that didn't have a ton of evidence in like the early 2000s, but people built up that evidence base over time. So there are strategies that have been tested a lot more rigorously than others, and the implementation literature can really help us figure out which of those are more evidence-based. The other answer to your question that is more like the peer-reviewed version is that there is a systematic review by Laura Ellen Ashcroft, and what it essentially did is they cross-reference implementation strategies used with studies that have had good implementation findings. And so what they did is they put together a table or a figure that shows, it's actually what is the online data system? Tableau. There's a Tableau for this. We can send out this article, and it actually can show you what the strategies were that were used in the most successful implementation research projects. So that's as close as we have right now to like a meta-analysis looking at what are the effective components of implementation strategies. That's something that is very much so the next 5 to 10 years down the road as we continue to develop that evidence base. But again, it's like 19 years old. We didn't start testing implementation strategies as rigorously until really the last 15 or so years. So there's still a lot of work left to be done. That's a great question. Okay, any other? Oh, right. So I'll continue with this if there are no other questions. So something that's often done, we we haven't talked about hybrid studies, but essentially hybrid studies are ways to test both clinical impacts of an intervention or program and the implementation outcomes at the same time. So in the same study, you have one aim that is testing one and one aim that is testing the other. There are different kinds of hybrids, and we can show you that in a second. But oftentimes, as you go later on into your research process, you've really studied that this thing is clinically effective, that it does what it's supposed to do. Your later studies would really look at things like light touch implementation strategies versus a heavy touch implementation strategy. So can you get the same bang for your buck with less of a heavy hand doing implementation? That's a lot of what hybrid type 3 studies look at, is really comparing light touch versus low touch, or light touch versus heavy touch or intensive touch. And another thing that we feel is very innovative and something that is not done, that is starting to be done more in implementation studies, is looking at sustainment after a study period has ended. So once a research team is pulled out, if you go back and evaluate what happened, how did it happen, what led to success in certain contexts and failure in other contexts, those are really innovative implementation studies to be doing right now. Any questions about this? All right. I'm curious, is anyone having any thoughts about ways they could build in an implementation aim into a grant that they're writing right now?
So I'm not doing what you just asked, but I do have I'm thinking about the thing that, the sort of content of any of these grant proposals. And it seems to me that these are all aimed at trying to help individuals modify their behavior in one way or another to improve health, right? And so I'm wondering if that is a kind of a limit around what we're conceptualizing as a thing, or if there are things outside of that individual level behavior domain that we might also be considering, like systems that structure individual choices. So how do you alter the decision-making environment in which people are choosing to do the thing or not? And that's sort of a different question. I'm wondering about, like, if you're changing the system as opposed to changing the individual, do you still need an implementation strategy?
That's a great question. So this question is around how much do you change, I want to make sure I understand, how much are you changing the system and implementation science versus the individual, and then the extent to which you would need an implementation strategy if you're going more at that system level change. That's a great question. So one of our colleagues, Clay Cook, who is now at this education program called Character Strong, he has a talk where he says implementation is just about behavior change. And that's like his tagline for the talk. And I think that's really true as an outcome. But I hope this answers your question. So if we look back here, I don't think I quite articulated this the way I wanted to. That these are, these are multi-level systems, right? And what we're doing when we're evaluating barriers and facilitators is that we're looking at, okay, the barriers at the individual level. We might have individual level strategies, but there might be barriers at the inner setting, the outer setting, which really encompasses that context. And there might be things about the way it's implemented that have determined how poorly or well it's implemented. So when we identify these different levels of barriers and facilitators, like in here, what we then do is then actually develop strategies at each level that address those barriers and facilitators at each level. So you are getting at the individual in some cases. That's like things like training, but there's also lots of changes you can make at the system level, like the nudge and the electronic health record system, that it's added to their overall context, or ways that you can actually, like, even facilitating things like the data aggregation might be an implementation strategy that you use that can help that system improve its functioning overall as well. And I think what I see, one of the things I see as I talk through this is that the service outcomes, I think, in this world really, this is focused on like a clinic and how a clinic functions, but the service outcomes, I think, in the world of climate and health is they're a little bit different. And I do see that bit of a misalignment, which made me think like, should we write a paper about that or something if it's not out there? But I think to your point that the focus on systems is, I think, a little more pertinent in the work that you're doing, and it's very like in your face. Yeah.
A few things I wanted to also just add is, first of all, I think a strength of implementation science is it's not just individual behavior change level. So as Ruben was saying, we want to make sure we're addressing the multi-level factors that are going to impact how well an innovation is going to be used in practice. There are kind of implementation strategies. One is the LOSI, which is the leadership for organization change. I'm not getting intervention. So basically what this strategy does is it addresses that middle level of organizational leadership, and how do we get organizational leaders to be more on board with adopting a policy for like their clinicians to use. I think we were using a lot of individual level strategies just because they're easy to grasp your head around. But we definitely want to look at things multi-level. The other thing I'll just highlight is that one of the things you can implement, like there are many different types of Ps. So you could look at things at a policy level. So a lot of my work looks at how do we get policymakers to want to put into place policies that are going to promote better individual level behavior change. So we might look at like, what are policymakers' beliefs about evidence? How do they feel about evidence? How can we influence policymakers? Or if this policy exists, who do we need to get involved so that this policy is actually implemented well in practice? When you do that sort of level work, the frameworks like the CFR might shift a little bit. And so you might have, basically, that's why it's helpful to define what the thing is, because then well, what is the organizational setting? Maybe if we're influencing policymakers, we're actually looking at like Congress and what's their organization like, rather than a clinic level. And so again, that's where it's helpful to define the thing, because then you can see who actually is operating at different levels. And maybe outer context in that case is like, what are news media saying? What are different cultural beliefs, for example, like outside of the policymakers, who's impacting them? So it gets a little bit complicated, and I'm sorry if I've confused folks, but the essential thing is that implementation looks at things from a multi-level perspective and tries to address barriers to implementing programs at all of those different levels. Yeah.
Let me know if you want to, I know we're close to time, so if you
Yeah,
want to
that's okay.
finish
We're
your slide,
fine.
or if you want to, I have a kind of higher level question. First of all, thank you very much. You're from Ronnie's group.
Yeah.
Okay. Great group. I do these types of trial, like the hybrid type ones. And so this group, I would just put a pitch in. If you're doing this kind of work, go there. Both, it looks better when you submit an application because they have the right bio sketches and they're like good partners, and also like are willing to do consults and stuff. So good center. I'm really, really glad you're doing the presentation. I wanted to ask, what is your link to Chair C? This is our first Chair C talk, so I'm kind of like itching to hear, like, do you have consulting time on Chair C for people who are giving in pilot? Like, what's your relationship to Chair C? If you weren't going to talk about that, that's okay, but I'm curious if like you're kind of connected, you're part of the grant, are you going to give free consults to pilots, or like what's your role?
Yeah, that's a great question. So I'm going to have Ruben talk about how you can chat with us more.
Okay.
I don't think we are formally yet, but we'd love to be, if that makes sense later on. Just because I think there's a lot of opportunities here where we could connect, which is why, I think some of this is also just starting some of that collaboration. But I'm going to hand it back over to Ruben to talk about how we can keep in touch.
So it's a great question. And we actually are Brown, we're housed in psychiatry, but we're Brown wide, and we have two different ways of working with us. One, so I'm the lead of implementation for Advance Our ICTR. So any Brown or really any Rhode Island based researcher can consult with me, and I can actually forward you on to other people in our group if there's someone you really want to work with. The other thing is that our bridge program, we do have consultations available. Typically, we limit those consultations if we're not going to be a co-I on a grant, given that it's a lot of time. So we are available to consult through Bridge, through Advance Our ICTR. We do not have a formal connection, but as we said, this is something that's really values aligned for us. And I think there's some porting and like shifting that can be done with some of the foundational work that we presented here that can be important for both fields.
I'm just gonna, in front of the camera, I'm just gonna step in here and shift us to the Q&A
Right.
part of this. And also in response to your question, I want to say, you know, Chair C is a center building grant. And so we are building a center. And the more of these workshops we have, and also as we gather, as we continue to support research with our SEED award program, which by the way, there are handouts about the SEED award opportunity that you all should look at. You know, we are interested in seeing what researchers in this community, the heat, health, and aging research community, want to bring to the project. Our focus on community engaged research means that this type of implementation science would be a very welcome component of a pilot project. But we're kind of relying on researchers to come to us with the teams that make the most sense to them. I see a lot of you looking like you're ready to go, but I am going to ask, are there any questions that, follow-up questions? We've already had some Q&A, but any others?
Yes. My question is, if you are interested in global health, would this be a center that you can reach out to maybe potentially work on projects or do just assistance with?
Yes, we have Alethea DeRogers. Oh, yes, the question is about global health research. That's definitely an area implementation science is already being applied to. We have a bridge member, Alethea DeRogers, and Greg Rosen, who does a lot of global health work. So absolutely, definitely reach out. And again, reaching out through either our newsletter, signing up for a newsletter will tell you more about different trainings we offer. But then you can reach out through one of these consultations. And, you know, even outside of this, like we're happy to chat. We're all colleagues here at Brown.